All right. Welcome, everybody. Thank you so much for taking time out this evening to come along and listen to this very important subject. And by our effort of all being here and the number of people on Zoom, it is a very important subject. And we need to learn a lot, and we continue to learn a lot. And I'm so, I feel so privileged tonight because we have two special guests. We have Professor Jackie Center, who is a clinician and researcher into bone health for many years. And we have Dr. Michelle McDonald, who is a bone scientist and is a researcher as well. So Michelle can talk all about bone physiology and how we can help ourselves as individuals to improve our bone density. And Jackie can talk about the future and where we're heading with research and with us as individuals and on a bigger scale. And most of you know me. My name is Catherine Moore, and I'm a physiotherapist here, owner and director of More Health, and have been here for 21 years. And I know many of you. And as 20 years passes quickly and we all get a lot older, it's been lovely to be able to look after you. And then the new faces, hello and welcome. So we might, first of all, also, this is very important, I want to acknowledge the Gadigal people of the Eora Nation, on the traditional owners of the land that we're on today, and to pay respects to all elders past and present. So as well, we must ask our questions, why are we here tonight? What brings us here? And I asked my question why I've gone down this rabbit hole of bone health. And you may have been given a piece of paper by your doctor that said you had some bone density issues, osteopenia, osteoporosis, some sort of bone decline, and you have a risk of fracturing a bone in your body because of that. Now, why would you want to do something about it when you feel quite well and you haven't hurt yourself really? And that happened to me. However, they're in a big picture as well. You see people have fractures and falls, and they become very disabled with that, and it's not a good way to be. So can we help ourselves? And I think there is some great things out there that can help us get better. And there's many things like lifestyle, like feeling, eating well, eating the right sort of food to nourish your bones. And then, of course, we have pharmaceutical drugs that help us. And then my specialty is exercise. Now, there's been a lot of science in the last recent years that's shown that there's certain types of exercise that really pinpoint and help bone recover and remodel. We do an exercise program here, which is called the Onero exercise program. I call it the game of bones. And you can, because science tells us, you can remodel your bone. Bone is living tissue, and it can develop and change and become denser. Personally, a little bit about me, at the age of 48, I was handed that piece of paper that said I had osteopenia. I had no idea what that meant. So I went on. Most of you know me. I'm a very active person. I love to ride my bike, play tennis, run, swim. So I thought that I was okay. Let's continue with that lifestyle. And every few years, like a good girl, I'd go back and have a DEXA scan, and it'd show decline, a little bit more decline. So come, a couple of years ago, I had a very nasty fall off my bike. My bike skidded, my push bike, and I broke my left shoulder and my right wrist. And I was actually quite disabled, pain and distress for probably about 3 months. It took me about 3 months to recover from that incident. Now, I wouldn't want to wish it upon anybody because it does disrupt your life. But the good part about that was I went down that rabbit hole of working out how I can improve and make my bones denser so this wouldn't happen. And that brought me around to learning about this exercise program, this high load, high intensity exercise program. And many of you here tonight are participating in this program. And I would say that what happened to me about 18 months ago, I started the program, and by good luck, 9 months later, I was due for my next DEXA scan. And I can tell you, I was amazed. I was handed that piece of paper and it said for the first time in 14 years that my bone density increased in my lumbar spine. Now, go figure. That's what I was doing to help myself. And I am passionate about this, that we can make a change as individuals. And let's be encouraged by the researchers who are discovering these sort of things all the time, and how we can all age much better and not have these disabilities. So I want to hand it over to you, Jackie. So you have to hold the microphone. And I want you to tell the audience a little bit about yourself and what you're interested in with bone health and where you see things are going.
Okay, thanks, Kath. And thanks for, introducing this and organising tonight. So I'm an endocrinologist, which means I deal with glands and hormones. I studied medicine after at uni. And I was always really interested in how we could actually work out sort of what happened after things, why, how diseases progressed. And so I learned a bit about epidemiology, which is sort of more studies of when you have large groups of people and you can actually follow disease and see what happens. I think you probably all heard about, particularly with COVID, we hear about how infections spread. Well, you can actually look at that with diseases as well. What happens afterwards? What are the risk factors? Why things happen like that? This was actually not very sexy at all when I left uni. In fact, the hospital where I was at, they threw up their hands and they said, why on earth do you want to do that? So I went overseas for a bit and then came back. And in fact, the only area where there was some epidemiology going on was in osteoporosis. In Sydney with the big Dubbo osteoporosis epidemiology study. I was actually not interested in osteoporosis at all. I was interested in diabetes because I'd done a lot of that overseas. And I had this futile discussion back and forth about, yes, you can come and do osteoporosis. And I thought, okay, that's fine, but I'll really do diabetes. Surely that will work. Anyway, I started off with osteoporosis. And I was really looking at what happens with people with fractures and what happens to them after fractures. And we actually were the first to show that not just hip fractures, but in fact, virtually every other fracture is associated with increased mortality. So particularly in older people, there's an increased risk of dying. And that was sort of the beginning of my journey into trying to understand what happens. And so half the time, since I finished the PhD, essentially half the time I see patients and half the time I do research. And so I see every day the impact of what happens when people fracture, particularly older people, what happens in terms of loss of confidence, loss of mobility, as Kath was talking about, and often spiral into the next fracture. But we can actually do a lot to prevent it. And that's the exciting thing, that what's happened since I started in this field, or since I started in hospital and now, is there've been huge advances in the understanding of bone, in the understanding of the treatments of bone, as Kath was talking about, not just medication, but also lifestyle and how important that is. And that's what I'm really passionate about. Just a few facts so that you know how important it is, that poor bone health resulting in fracture is the fastest growing chronic disease in Australia over the last 10 years. It's increased 100%. It's grown faster than diabetes, than cancer, and heart disease. Yet, who's really interested in osteoporosis? Who's interested in this? What do we hear about? We hear about cancer. We hear about heart disease. We hear about diabetes and how important that is. It's almost like a silent disease, and that's something I think we have to get across out there. Did you know that about 6 million people in Australia have poor bone health or osteoporosis, and that more women actually will die from a hip fracture than from breast cancer? Okay, so it affects a lot of people. But apart from mortality, we know that after a fracture, there's an increased risk of another fracture, and that in New South Wales alone, in the last 10 years, people who came into hospital for their second fracture, that number increased 63%. So that over 14,000 people in New South Wales come into hospital every year with their second or third or fourth fracture. And the important thing is we can prevent that, but we're not doing that. Less than 30% of women who leave hospital, and it's even worse with men, with a hip fracture, which, as we know, is probably the worst fracture in terms of outcomes, are sent home on treatment. So we're doing really badly. And I think a lot of it is because people, and I'm talking about generally in the community and also the treating physicians, really do not understand the consequences of fracture. And that's something we are trying to understand. We're trying to understand what in a fracture causes the subsequent outcomes and how we can actually get this out to people so that people will know more about their fracture and what to do. Research funding for osteoporosis has actually declined in the last 10 years by well over 30%. So that's a big problem we have as a community, and yet it costs over $3.8 billion per year just for fractures, indirect costs, let alone the days not spent working and carers and that sort of thing. So it is a huge problem.
Be asking you some more questions, but before we do that, Michelle, if you don't mind telling us a little bit about your research, a little bit about yourself and what you do every day and how, it affects us.
Hi, I'm Michelle McDonald. I'm currently actually associate professor. So I'm a junior professor, I guess you'd call that. The next step for me is to become a professor, but I'm not a clinician. I'm a scientist, as Kath said earlier. So I did a medical science degree for my undergrad degree, and then I went on to do a PhD, and that was 20 years ago now. So I've been actively researching in the space of bone biology, specifically for 20 years now. So I am what I call a bone nerd. I'm a bone biologist, and I've thrown my life into, I guess, really understanding the skeleton. So I worked for about 10 years for an orthopedic surgeon, and in that space, I actually worked in fracture repair. So I learned an awful lot about how the skeleton heals and the biology around it and how we can actually improve that process, because there's a lot of situations where a fracture doesn't heal well, and we were looking at ways to actually enhance that process. So I was raised in a research space, but by a clinician, which was been a really critical part to forming the sort of researcher that I am. There's a lot of fundamental researchers that sit in the lab and answer some really heavy fundamental biology questions. But I'm a research scientist that likes to work with clinicians such as Jackie. So Jackie and I have been working together for about 12 years now. I like to work with clinicians and really start to model what's happening in the clinic and answer the questions that can't be answered in patients by modeling that. So I'm really asking those really important clinical questions with clinicians like Jackie, and I speak to them at what questions, what things do you not know and that you can't find out looking in humans? And I model that in the lab. And that's the sort of research that I do. So I've been very lucky to have spent a lot of, and I've made sure I've spent my career working with clinicians such as Jackie so that I can really answer those key questions. So I've moved to Sydney University about 18 months ago. So I was at the Garvan Institute with Jackie for about 12 years working in research, as I mentioned. And then I moved about 18 months ago to Sydney University, where I'm now also doing teaching. So I'm lecturing to science students, I'm lecturing to medical students and teaching them bone physiologists. So they're bringing that research expertise as well as my knowledge base into the university to lecture and teach to the students. So I'm now kind of like Jackie, instead of 50% research clinician, I'm 50% research and 50% teaching. So I'm able to actually pass on that experience and knowledge to the next generation of scientists, hopefully encourage them to move into a space like I have and pursue this, because it's a very important component of medicine research. I feel very privileged to sit in a position where I get to actually teach people like Jackie. Jackie comes to me and asks me sometimes questions about a patient. What do you think I should do with this patient? Which is really a fun part of my job. So that's what I do. I teach and I run a research lab. So I've got PhD students and research staff that I lead, and I've been applying for grants and modeling and asking some key questions. So just to give you an idea of some of the questions that I'm currently trying to answer, which is something I'm working very closely with Jackie on the past few years now. We co-supervise a PhD student who is an endocrinologist. He's come into my lab and he is modeling a really key question that has become really important in the management of osteoporosis, where there's a treatment called Prolia that is administered to quite a large number of osteoporosis patients now. But there's a big issue that we've discovered in the clinic that if patients stop their Prolia treatment, so this is a treatment that builds their bone density, if they stop their Prolia treatment, they actually lose their bone density really rapidly, and they have a very high fracture risk, particularly vertebral fractures. And that's become a really big issue because there's 350,000 prescriptions of Prolia every year in Australia. And if those patients stop treatment, they're at really high risk of quite dire consequences. So I've actually been modeling that in the lab, and we've found some really interesting findings to understand why that's happening and to look at ways to prevent it. So those are things we can't do in the clinic. So we turn to the lab to answer those questions. And that sort of work is helping people like Jackie and inform them so that they know how to manage patients. So that's who I am. That's what I do. And I guess I'm here to help with any questions that people might have to really understand the biology around why exercise actually helps our skeleton and our skeletal health, and it helps us build new bone mass. And I have actually modeled that in other studies in the lab. I've modeled how the skeleton responds to these sorts of loading exercises, so we understand why it's a benefit to our skeleton. Do you think that covers everything?
Yes, and I'm going to be asking you some curly questions.
Yeah, I think just like Michelle, I feel really privileged to be able to work with people and then actually understand what are some of the concerns people have and what are some of the things we don't know when they ask me and I say, oh, I'm not sure. But then we can look, the research that I do looks at large populations and tries to look at what are the things leading from one thing to another. So it involves quite a lot of sort of modeling of numbers and people and statistics and things like that, and answer some of the questions that I don't know from what I see in patients. But then what's also fantastic as well is to work with basic researchers, people like Michelle, because some of the things we can look at and see that, yeah, this leads to that, or this looks like it's associated with it, but how exactly does it happen? can we prove that doing one thing leads to another? Some of that needs to be done in animal studies, which we just can't do in humans.
Well, okay, I've got some questions. So I'm going to start with you, Jackie. Now, you're researching half your time. Now, I'm very curious to know what you're doing in those days, what your plans are, and if funding is a difficulty, what's the future of the research? And so what is the research you want to do and what's the future?
Okay, so I guess there's two probably fundamental issues that I see at that we're doing in our research at the moment. There's plenty of issues surrounding bone because, as Michelle said, bone is really a living tissue. One of the things I've learned over the years is that I think we think of bones often as the things that get us from A to B. That's true, but they also do a huge amount of other things as well. Bone's really alive, and it's modeling, and you replace your skeleton every, I think, 15 years, 10 to 15 years. So the bones you have now are not the same bones that you had 10 to 15 years ago. There's blood vessels that go through bone. The bone makes, inside the bone, there's immune cells. So things happen when you fracture that disrupt all that process. And we know that these bad things happen after fracture. And we know that it's worse after some fractures than other fractures. And I think what we are trying to understand is, what is it? What are the things that are associated with why people do badly? Because if we can make people understand that actually bone health and fractures are as important a problem as heart disease, which everyone is concerned about. Everyone gets their cholesterol treated, but no one really thinks they get a fracture, they get it treated, and they get it fixed by the orthopedic surgeon, and then that's done. It's not even often mentioned to the GP, but in fact, it has consequences down the track. And if we can understand what leads from one thing to the poor consequences, the risk of another fracture, the disability, we know there's increased risk of not being able to live by yourself. Why do people are more likely to die than someone who hasn't had a fracture of the same age? And we know that there's a lot of other diseases, for instance, impact that. So that we've shown that if you've got diabetes, for instance, even if you've got heart disease, that having that as well as a fracture is actually a lot worse, but we don't know how these interact. So that's one of the big questions that we're trying to answer. The other thing that we know is, how do we get this information out to people? How do we make people and doctors respond better so that we get more people treated? We get more people who are on the appropriate medication. We get more people who do the appropriate exercise, and we know that we need calcium, we need vitamin D, we need protein to feed our bones and make them healthy. How do we get that information to people and make people at the time of the fracture, or those at high risk of fracture, appreciate that information so that they can actually take charge of their health themselves? So we're looking at developing a risk prediction app or tool that will help put all the risk factors together, everyone's what their other conditions are, a whole lot of things, so that we can predict those people who are going to do badly, and then individualize management for those people. So I guess in a nutshell, big ambitions.
Incredible. It makes a lot of sense to me that, this is what we need as a society, isn't it, for the future? I mean, 10 years goes quickly, 20 years goes quickly, and we're all getting older. Unfortunately, we're not going younger. But anyway, so Michelle, are you ready for your question? Okay, so we as individuals are wanting to change our bone density, our bone health. Now, we do exercise in the gym here. Now, I'll work a exercise question first of all. One of the exercises that we do is like a heel drop. We thump our heels and feel a vibration through our body. Can you tell us what happens to the bone and why that is good?
Absolutely. So I'd like to start by, I think one thing that people don't really appreciate is our skeleton is incredibly responsive to load because it has such an important role. As Jackie's just said, it's not just to help us walk around. It also protects our organs. It plays such an important role in supporting us. And one thing people don't appreciate is when astronauts go up in space, they actually lose a lot of bone mass because they're not loading just from walking around with gravity. So just walking around, we're loading our bones, and people even on bed rest can lose bone mass and actually have issues with their bone density. Huge amounts of, do you want me to stand up? Sorry. Huge amounts of bone density just from being really immobile. And there's even people who have not loaded on one of their legs. So there's disuse osteopenia, we call it. So it's very responsive to load. And if we unload it, we lose a lot of mass. Walking around as a young person, running, a young, active young person, keeps our bones nice and healthy. As we age, we're not quite as active as we used to be. We're not running around, and we tend to also, unfortunately, lose bone mass as we age because we're aging, but also our hormones, particularly women, play a huge role in how our bone responds. So it's really important we kind of look at ways to get back that level of bone responsiveness that we had when we were younger or when we were running around and doing more of that activity. So we need to actually load and kind of exacerbate the loading forces we're putting on our bones to kind of wake them up again and say, right, I'm loading, I'm loaded, I need to respond to that. So how does the skeleton respond to that load? Well, we have these little cells that sit inside our bone matrix. So the tissue that's really hard, we know that our bone tissue is very hard because it has to provide that structure, is full of cells. There are cells all through that hard matrix, and they're called osteocytes. And they are mechanosensing cells. There are other mechanosensing cells in our body, but the osteocytes are really very important cells to this mechanosensing response. And they're all through our bone tissue, and they have a little network. They're all connected to each other, and there's trillions of these cells, and they have all these finger-like projections, and they connect to each other, and they have this fluid that kind of runs in this space between them. So there's a fluid that sits in all these little tiny little connections that run through our bone matrix. And every time we're kind of loading our bone, there's a little bit of a shift in that fluid, and those cells have these little hairs on them that move, and they respond to that load by telling the cells that make bone matrix to make more bone. It's as simple as that. So those cells are listening and feeling that load. So when you're slamming your heels on the ground, that's kind of like a push up a compressive force, and that changes the fluid flow running through our bone tissue. And those cells respond to that, and they send signals to the surface of the bone because remember, these are sitting in the bone tissue, and they tell the cells that are sitting on the outside of the bone to make more bone because they're feeling that load and they're responding to that, because it's kind of like you've gone back to being a kid running around and jumping and playing ball sports and things. So you're kind of loading your skeleton. So you have to think about really exacerbated loading. But you don't have to do that all day, every day. You just need to do that as part of a program like this Onero program a couple of times a week, and your skeleton will start to really respond to that. Does that answer that question? I know it's a long answer, but
it's fascinating. I'm picturing the bone and the tentacles and the cells, everything, and how it is living. Okay. And what do we need to do with something that's living? We need to keep it moving. Now, another thing, and I'm sure people come in to see you all the time and talk like this, very active 60-year-old. And here I am on the decline, and I'm cycling, I'm swimming, I'm playing tennis. But why am I not being helped with my bone density? And then all of a sudden I do this weightlifting program and it changes. So maybe, I don't know, who wants to answer that one? Why is there a shift? Why is there a change?
This particular type.
You with this particular type. So swimming does nothing to our bones.
And Michelle answered that really, because it's not loading the bones. It's the same as cycling. It's good for your muscles and it's good for your health in general. And but it doesn't actually load the bones. So yeah, so this jumping The strong weights, lifting the heavy weights that Kath does in her program, that actually loads the bones. And the research has shown that you actually need that heavy loading to make a difference in terms of bone modeling and getting additional bone. And I mean, there's other things that we can do as well. We certainly know, as I mentioned before, that you need enough calcium, you need enough protein, because that's what goes into your bones. You need to have a certain amount of vitamin D. We know that there's various other conditions that are more associated with losing bone. And that's sort of become specialized. But if you're losing bone despite doing all these things, then you need to look for something else, because there are other things that can impact bone as well. Does that answer?
Fantastic. So here we are. We as individuals can do things. Now, one big conversation I have with people in the clinic here is about diet and about intake of calcium. And the recommended dosage every day is 1,300 milligrams. Now, this is a lot of milk. People aren't very happy about drinking a lot of milk a lot of the time. Okay. So, and I know there is a dietitian in the room, so she may be able to help us out as well. But also there's an issue with cholesterol, heart disease with the fats in these sort of foods. So how do we get this calcium? And the other very interesting question, which Lynette asked me, was she was told that some foods you eat don't help absorb the calcium. So I got very confused then, but maybe we should keep it really simple. But how can we help our diets by having the correct amount of calcium for our bones to keep dense?
And it's not an easy question, because it is quite a lot of calcium that you do need. But I think you can break it down and think of it simply. And this is what I generally say to people, is that I think of calcium intake in serves. So a serve of calcium is about 300 milligrams. So if you're having a general healthy diet, you're getting about a serve from non-dairy stuff, from nuts, from grains, from legumes, multigrain bread, that sort of thing probably gives you, that's the studies have shown that probably gives you about a third, about a serve of calcium. So you need to find somehow 2 or 3 more serves. If you like dairy, then it's easy, because you can add, a serve is about a cup of milk or a small tub of yogurt or a couple of slices of cheese. And you can vary that throughout the day. Also remember, it's not an exact science. So we say 1,300 milligrams, and I'll probably be shot down for saying this, but some people may, we always like to think that everyone's exactly the same, but there's probably a variation, and it's probably not exactly 1,300 milligrams. If it's 1,100 or 1,200, or it does vary throughout your life as well. So I'm usually not sort of so hard fast about having exactly the amount. We can do some tests, simple tests, to actually get some idea of how much an individual, if they're getting enough. But there's other apart from dairy, and firstly, you can have low-fat milk and yogurt. So that has as much, if not more, calcium. You can have non-dairy sources, fortified milk with soy milk, or there's lots of fortified almond milk that have calcium in them as well. You've just got to make sure it's fortified. Then things like tin fish with the bones, because the bones in the tin fish are very high in calcium, so tin salmon and sardines. There is a tuna, doesn't have calcium, but there's a John West high calcium tuna. that actually a little tin, 100-gram tin, has your whole day's, almost your whole day's serving of calcium in it. So that's actually a handy tip. And there's some fortified cereals that have calcium in them. Other things like prunes, nuts like almonds, you've got to eat a lot of them. And broccoli, for instance, you need 1 kilo of broccoli to get the same as a cup of milk. But, you know, if you're having a bit of that sort of thing, and spinach, leafy greens, if you're having some of that stuff, you know, along with your diet, you're getting some. And if you're really stuck, you can take a calcium supplement. We just, you know, and it may be that you only need half a calcium supplement, or it may be that you don't need it every day, but just sometimes. You know, it's very flexible, and it can be something that can, you know, really be individualized. Because let's face it, you know the foods that you like, and it's if someone says to you, you got to drink 3 glasses of milk a day, and you hate milk, you're not going to do it.
You just talked about supplements and the calcium, and then I understand vitamin D and protein are very important as well. And how does that work? Why is that important?
Well, we need the vitamin D to help us absorb the calcium. It's sort of as simple. It helps the gut absorb the calcium. It does some other things as well, but essentially it helps with the calcium. We need protein because the bones, not just calcium, but they need enough protein. And one of the things that happens often as people get older, and particularly when they're living by themselves, is it's very easy to have, you know, toast and jam, rather than, which doesn't have a lot of protein in it, rather than have the adequate sources of protein that you need. So particularly in older people, we find this a lot, that they're actually protein deficient. And that's where I would, you know, hand over to a dietitian to give more sort of, you know, complete advice about what someone needs. But that is certainly very important. My husband can attest to the number of times I tell my mother, is she getting enough, to make sure she's getting enough protein.
Yeah, so we've got some ways that we can improve our bones, that we have to, as individuals, apply ourselves. It was diet, lifestyle. I think stress, reducing your stress would be helpful, because I'm sure that would affect your gut. This is all my own interpretation or my own science, that would affect your gut and would affect your brain. So then the absorption of these beautiful nutrients wouldn't be happening. You'd be too tired to lift weights because you're too stressed. So lifestyle is important, getting your sleep, getting your good nutrition. And then, of course, there's the pharmaceutical drugs. Now, that's a big minefield. And I think that's a very individual thing for different people. And then, of course, yes.
Can I just say, it is a minefield, and I don't think that's sort of the place for tonight, but we know they're very effective. We know they're very effective in reducing the next fracture. We've demonstrated also that they probably have an effect on reducing the mortality. We don't know the reasons why, but medication, and it is for a certain person, you know, for certain people, is actually very effective. There's a lot of concern about some of potential side effects. A lot of that is sort of has been misreported. So I just want to say that, you know, there's all these things, and it really depends on an individual person's fracture risk and where they are in their life as to which things you know, ideally you do all of them, but some of them you may not start initially. And that's one of the reasons why we're so concerned and really want to define what are the things that help, you know, a particular person and who's at high risk, and therefore how we need to intervene best for that person.
Can I add to that, Jackie? If one of the things you touched on earlier is the fact that more people and more fractures. We're still seeing an incline. Even though we've got some quite good pharmaceuticals out there, we're learning an awful lot now about how we can exercise and diet and do a better job. But we're still seeing an incline in fractures. We're still seeing an incline. Do you think that's because we still need to better educate people and GPs about the treatments that we have, also in addition to exercise and diet changes, so that there's more certainty and confidence around the treatments that we have to then apply them and then prevent more of these fractures and prevent the incline in osteoporosis?
Yeah, absolutely. As I said, I think there's fear about medication, and a lot of that is unwarranted fear. I think that other physicians and say cardiologists, for instance, you will hear cardiologists say, don't take calcium because you've got calcium in your arteries. Okay, so there's a lot of ignorance. Let's say people are concerned about their specialty and often don't know other things. And no one sees the connection between what happens after you've fractured, what happens to people with osteoporosis. And so they don't think that the medication is necessarily important. They don't see what happens with the next fracture and how high a risk someone is of having one and then the next. You know, you just see people who have spine fractures and what it does in terms of not being able to stand straight, not being able to lift things, being in pain most of the time or a lot of the time, what that does to someone's confidence, how they can go out, they can't manage their own shopping. You know, you really can see what it means to people's life and their quality of life. And after all, that's what we really want. You know, as we age, none of us want to really go to a nursing home. And you will hear, I mean, I see it and I hear it. So-and-so had a fall, had a fracture, and they're no longer able to manage at home, and they had to go to a nursing home. That's really what we want to prevent. And the medications, in addition to everything else, are actually very valuable. But there is a lot of, it's not broadcast. You know, osteoporosis is, you know, there's cancer up there, and you see all the promotion and funding and everything for breast cancer and all the other cancers. There's been a lot around pancreatic cancer, and we know that cancer is bad, but so is osteoporosis, and it's so common. You know, after the age of 60, 1 in 3 women will have a fracture in their lifetime, and or actually, yeah, 1 in 3 women over 50, and something like 1 in 5 men. 1 in 8 women will get breast cancer.
Most, they don't pass from breast cancer until it's metastasized and spread. So I actually work in the space of cancer as well. Sorry. Yeah, and medicine, but it is actually more common. But I think the thing people don't appreciate is that then it's the metastatic disease that people progress to that actually leads to the mortality and the survival issue, which is not all women, you know, 1 in 8 women, but osteoporosis, 1 in 3 women have an osteoporotic fracture. And that causes the change in mortality, and which is a huge increase, as Jackie's work has shown. So I think that's the communication that's been lost to the public. Very important that I work in this space, that cancer is funded and understood, but we need to lift the profile of the importance of osteoporosis. And that's something that Jackie's work has played a huge role in doing so far, but we need to take it to the next step.
Yeah, I mean, after a hip fracture, we know that 20 to 30% of people are dead within a year. Okay, and
hip fractures.
Just because the people on the Zoom link.
Oh, so sorry. Yes, I'm almost 68, but when I was 39, I was a flight attendant. I slipped in the bathroom so I had 3 big screws put in there. And then a few years later, because I was with Qantas fighting over, domestic and international, and I had a hip replacement. And then in the last 3, then I needed a knee replacement after that because I'd been carrying this problem around in my femur. The tibia had miscued. So I had that. So I had a hip. So I had. No, you can't have it.
I'm going to ask you a question. You're very resilient. You've got through, what was it, 4 fractures? So well done. So you're doing something special to help yourself. What do we say? Good genes. Okay. Oh, no. Okay. All right.
But I guess that goes to another point, that your genes are really important. And your genes are really important in terms of what your bone density is. And your genes are really important in terms of, we know that some people can do anything. They can smoke, they can drink, and they're going to be okay, but that's not everyone. And we actually don't know. We don't know whether we're going to be one of those lucky people or one of those unlucky people.
That's
Not that you were lucky to fall.
So the magic of life. We're all different. But really what I think, if we direct back to the research, let's look after our society as we get older. Who wants to be, sending people off to care facilities because they're disabled? Let's look after ourselves now. Let's support the research, which will make it more public. That's what we want, isn't it? We want the world to know how important this subject is. Yeah.
So, as Michelle said, and obviously, this is really important to me. Because I actually think we can do something to make a difference. I think we've got to a point where we can actually now start putting some of the clues together to actually to make a difference, which is what sort of drives me to continue the research, because there's a lot of frustration in terms of trying to apply, as Michelle knows, for grant after grant after grant, and osteoporosis, the funding is going down like that. So there's, the grants you spend 3 or 4 months writing, you've got about a 5% chance or less of getting. Well, that's true. But I think the other thing, so there's that, and the other thing is getting the word out there. We really need for the politicians to know how important osteoporosis is. We see it because, and most people, when I spoke to some group, I can't remember when, and I said, put up your hand, those who know someone who've either been related to someone who knows someone who's had a fracture, half the room put their hand up. So we all know how common it is, and we all just need to get that word out there to lobby, to make osteoporosis sort of come up from right down the bottom of, the interest into something that's seen as being important.
So I might ask, unfortunately, Zoomers, you probably won't have this opportunity, but is there any burning questions from the audience? You do need to use the microphone for one of the panel.
Thank you. I'm just curious about the calcium. I'm one of those people who was told not to take calcium, the tablets, because I have a heart condition. I also am lactose intolerant, and my cholesterol would be sky high even if I lived on water. So I don't know what to take. Is there a special calcium? Like normally it's calcium carbonate. Is there a different one that works better? Or I don't take any. But what would you recommend? Other than foods.
So I think I don't think I can give a personal recommendation because I think I'd need to actually find out a lot more about you. But in general, what I do is I find out how much people take from their diet. And then if they can't have more, and there's various different types of calcium. Well, it may actually depend on personal, what other medications you're taking, for instance. So, but there's no point having more calcium than is going to get absorbed. So I think if you're getting enough from your diet, you don't need any. You don't need to take a calcium supplement. If you're unable to get any from your diet, then you do need to take a calcium supplement. And we can do some urine tests to find out, if you're getting enough calcium, or gives us an idea if you're getting enough calcium. So I would certainly not prescribe a tablet to everyone, but it needs to be individualized, and the type of tablet needs to be individualized.
I do like investigations. I think that urine test, which is very uncomfortable to do for 24 hours, is probably the best measure.
Yeah, it's one of the best ones that we have at the moment. That's not complicated and, too difficult to do. But only in research perspective. In terms of what we do in clinical practice, that would be it. Yeah.
Do you know what? There is a wonderful dietitian in the room, and you might want to meet her, and she can talk to you about calcium. Yes.
I have a tough one for you, Michelle. When I was growing up, we had tennis shoes, and they all had the shoes I'm wearing now had hard soles. All the running shoes are all cushioned now. I'm sure that's having an impact. Has that ever been measured?
It is a very good question. Look, I don't think anyone's looked at that. I don't think we can answer that question. I still think you're going to get a lot of load running. If you are out running, you are loading your bones. If you've got a little bit of extra cushion there, you're just helping yourself a little so you're not loading your joints and damaging your joints in the process. I'm a runner. I still try to run, but I'm in my mid-40s and I'm finding it harder to run. I go to the gym and I lift weights, and there's no cushioning in that place, and that's way better for my skeleton than going for a run. So if I want to actually keep exercising and keep my skeleton healthy, because I'm heading towards menopause, it's going to happen soon, I'm sure. I lift weights at the gym. I go to the gym and I push really hard lifting weights because I know that's way better for me than running anyway. And in that case, cushioning in my shoes wouldn't make any difference. So, but I don't think anyone's looked at that specifically. Still, you would still load your bones by running, absolutely, even with a whole lot of, even if you're running on like there was like air or something there. Still get some.
We've got a few minutes left. Let's go.
Thank you. How does the Onero program and the drug Actonel interact in increasing your bone density?
Why do both?
Yeah, not why do both. I mean, I understand that, but how does the Actonel? What is the process in the bones when you're taking the Actonel and then you're doing the heavy Onero program?
That's a great question. So something that Kath touched on that earlier, she talked about remodeling. So remodeling, Jackie spoke to that as well. Your skeleton turns over every 10 to 15 years. You've got a completely new skeleton. Whilst you're sitting here right now, your bone cells are turning your skeleton over. They're remodeling. You have two cells that do this. So we've talked about the osteocytes that have the connections inside your bone tissue. They speak to the osteoblasts, and they're the cells that make new bone. And then we have the osteoclasts that are kind of like Pac-Man that come along and eat your bone. So the osteoclasts eat your bone. That then signals to the osteoblasts to put new bone down, to replace it, to keep it really healthy. So the drugs that we use in the clinic mostly target those osteoclasts that eat your bone. So they're called anti-resorptive drugs. They will stop your cells that eat your bone working. So that stops slows that process down and stops that component. So you get like a balance. You've got more formation and less resorption. So you get more bone. So that's how you increase your bone density on those treatments that we have. Exercise on the other side is what's stimulating new bone formation. So your osteocytes are responding to that load, the cells that are sitting inside your bone matrix. They're sensing the load and they send a signal to the osteoblasts that make new bone to lay down more bone and make more of your skeleton, as well as your osteoclast to maybe eat less of your skeleton, because the idea is you end up with more bone. So the two of those things combined are essentially going to get an even better response and an even greater gain in your bone density, because you are stopping the cells that resorb bone and you are telling the cells that make bone to make more bone. So in effect, you are shifting the balance even further. So by doing both of those things, you can actually get an even bigger gain.
Can you actually increase bone density by taking the drug Actonel?
Actonel?
Yeah.
Yeah, that's one of those drugs. Jackie actually prescribes these drugs.
Yeah. You do increase your bone density, yes. It usually increases and then it plateaus, because what happens, as you know, Michelle has said better than I will say, you know, the cells that chew up bone, the osteoclasts, you then get the cells that make new bone sort of come and lay bone in those pits that have been chewed up, so that that gets replaced. And the Actonel works by slowing that down. So those pits do get replaced and you get bone filling in those holes, if you like. And so you will increase your bone density. But you will eventually get to a sort of a new steady state. And so you'll see an increase, but it will start to plateau.
Most importantly, you will stop losing bone mass. And that's what we want to stop, because if you're getting in early and treating early, before you fracture, before you're at a point where you've lost bone and you're fracturing, you're stopping the loss. And that's.
Okay, so the question was, how long does it take for that drug to work? We certainly know that you see a difference on fractures within a year. So, and I mean, that's the end point that we really want to look at. And there's some very early data, and it's not yet very good, but that exactly as Michelle was saying, that the loading plus the medication works better than either one.
So I want to respect everybody's time. We're up to 7 p.m. So would you like to go further? There is a few more questions. Would you like to have more time? Okay. Well, thank you. And there's same with the Zoomers. If you want to go, that's fine. Okay. We got Bridget.
Another Actonel question. Should we be taking Actonel forever, or particularly if we're doing the Onero program, is there a point when we can stop taking Actonel? What's the best thing to do?
Again, a tricky question, okay? And it has to be individualized, okay? So there are some potential risks with taking the medication long term. They're really, really rare. Much, much rarer than the benefits you get from the medication. So, but there is this risk of what's called an atypical femur fracture, which is a stress fracture through the thigh. It's estimated that, you know, for every one of those, you prevent about 40 hip fractures and about 400 other fractures. So it's, you know, 1 in 10 to 100,000 people. So it's very, very rare. But the longer you've been on medication, that risk, which is incredibly rare, goes up a little bit. So it's still rare, but it does go up. So what I was saying before about individualizing, if there's someone who hasn't had a fracture or hasn't had a fracture for, let's say, 10 years, their bone density is now good, they're doing the other things, the Onero program, and lifestyle's good, certainly you may consider absolutely giving someone a break from the medication. Not only are they no longer at high risk, and that's what you really want to know. What is your risk? So what do you need? Actonel, there are other medications as well, other than Actonel too, which might be better for you, for instance, if you're at particularly high risk. But if you stop the medication, even for a year, that very, very low risk of atypical femur fracture goes almost back down to baseline. So there actually are some good reasons for stopping and then maybe starting again. But not all medications can just be stopped. So that's where, and Michelle was talking about Prolia or denosumab that you may have heard of. You cannot just stop that because that has dire consequences. So you really, the strategy of which medication for which person and when does need to be thought out. So that's a really good question. And there's a lot of uncertainty out there, but it's virtually all women. Okay. I mean, perhaps there'd be some who maybe not, but virtually all women will lose bone at the menopause. In fact, you actually start to lose bone before the menopause, when you're probably in the year or so prior to actually menopause. There've been good studies, these big people studies where they've followed people over time, and you can see that you lose bone prior to the menopause. So around the time of menopause, or, when you start noticing that things are changing, is a good time to actually have a bone density and see. I mean, you might be one of those really lucky people whose bone density is above the normal range. And if you lose some, it may not be so important for you. But if you're starting off at a low level and then you lose, that's bad, right? Why don't we try and prevent the loss? You can always also measure your bone density in a year or so and see, have you lost, because you can actually lose bone very fast at menopause, between 2 to 5% a year, which is, a lot of bone. As you get older, we tend to lose bone, but it's less than 1% a year, so it tends to continue to go down. But at the menopause time, you can lose between 2 and 5% a year. And that loss continues for around 5 years or so. So if you're losing at that rate, if you're one of those fast people who are losing fast at that rate, you're going to lose a lot of bone and not know about it until it's too late. Well, it's not too late. It's never too late, because it doesn't matter if you're 95. If you're well and living in the community and then fracture at 95, that's bad. So we can intervene at any time. I don't think it's ever too late to intervene, but we can intervene early. And HRT, or hormone therapy, will prevent that bone loss completely. And if you actually lose some and then start hormone therapy, you'll see an increase in the bone density.